Welcome everyone to the Antimicrobial Stewardship Project webinar series, created by the Center for Infectious Disease Research and Policy at the University of Minnesota. I'm Dr. Marnie Peterson, your host and the outreach coordinator for the project. Today we are very excited to have with us today Dr. Elizabeth Monsees. She will be presenting her webinar titled, as you see there on your screen, The Central Steward, Exploring the Role of Nursing in Antibiotic Stewardship. We're very excited to have her here today, and this topic is one of keen interest to us, so we're happy that our participants have joined us. But before Dr. Monsees begins the webinar, I'd like to provide a brief background and summary of her experiences, and you will clearly see that she's an expert in this field. She's a registered nurse. She has her PhD as well as her MBA and has numerous years of experience as an infection preventionist and clinical safety officer. Currently, she's the Antibiotic Stewardship Program Manager and Senior Patient Care Services Researcher at Children's Mercy's Hospital in Kansas City, Missouri. In these roles, she studies factors that influence direct care nurses' participation as antimicrobial stewards. She's been involved at the society level. Dr. Monsees has helped to develop the American Nurses Association, U.S. Centers for Disease Control and Prevention white paper on the role of registered nurses in antibiotic stewardship. She's a member of the Society for Healthcare Epidemiology of America, otherwise known as SHEA, Research Committee. She has served on several committees for the Association for Professionals in Infection Control, APIC, including the Education Committee, the Communications Committee, and the Nominating and Awards Committee. And she has authored several chapters in the APIC text online, including the first Antimicrobial Stewardship chapter. And she also serves on the editorial board for the American Journal of Infection Control. In addition to all of this, she's delivered numerous presentations at local, national, international conferences and travels the world teaching and educating around the role of nurses as antimicrobial stewards. Before she begins, a few instructions to our participants today. At any time during the webinar, you'll see there's a chat box at the bottom right-hand corner of your screen. We really welcome you to engage with our speaker today using that chat box. Any questions, any comments, please send them to her there. And we will have time at the end of this presentation for that engagement and discussion. And finally, just to note that the webinar is being recorded, and we will be able to have this posted to our website via our YouTube channel following our live presentation today. So with that, Elizabeth, I'd like to welcome you to the Antimicrobial Stewardship Project webinar series today, and we look forward to your presentation.
Thank you, Marty. This is fantastic. Thank you, everybody, for the opportunity to present to you today and for joining us in this webinar. So as Marty mentioned, I will be discussing the role of nurses in antibiotic stewardship and really terming them as the central steward as they really function in so many different capacities with different disciplines, and we'll explore that a little further. So the learning outcomes today are really to explore the current science and describe what we currently know about barriers that may inhibit the full participation by nurses in antibiotic stewardship. But my goal is really to leave you with a few strategies to talk with your nurses and to build partnerships in practice. So you may be wondering why I have some different articles from the early 2000s. And when I was preparing this webinar, I was reflecting on some of the formative learning experiences when I was an infection preventionist in a small community hospital a number of years ago. And at that time, we were experiencing a clustering of C. diff outbreaks, and along with implementing a variety of different strategies, I was reviewing articles to identify additional strategies to mitigate those ongoing outbreaks. And so when I approached my very thoughtful medical director, we kind of talked about the idea of addressing antibiotic use. And at that time, he said, Elizabeth, we really just do not have the bandwidth in which to do that. And that was, I think, very surprising to me because our concerns had really reached the level of conversations with the CDC around the ongoing outbreaks that we were experiencing. Now you fast forward to today where stewardship is really a required component of care. It's really hard to imagine when it really wasn't a fundamental part of our practice. And I think the reason I share that story with you is because I really learned how important it is to really understand organizational culture, and that message that was really later reinforced when I worked in safety. And I really learned you can have these really great work processes. You can have a very well-educated workforce that understands the issue. But as we really are thinking about reimagining these types of stewardship teams, context matters, particularly in team-based professions like nursing. So as we enter a space where we're reimagining what stewardship looks like, I think it's really critically important that we leverage this large discipline that can help us broaden the efforts and really assure that progression of stewardship across the care continuum. And so with that, many of you are probably very familiar with the Olin's article, which was really that catapulted nurses onto the stewardship radar in 2015. And what they identified is that nurses, and it's a great term, there's an unrecognition of the practices that nurses already perform on a daily basis that support the process of antimicrobial optimization. And that really begins from the point of taking an allergy history and making sure that that's appropriately documented, all the way through the mitigation of C. diff transmission and everything in between that we've listed. And though the CDC core elements and various core agencies really call for this really diverse composite of professionals that are committed to making sure antibiotics are used appropriately, a recent study by Valerie Vaughn out of Michigan really evaluated the composition of various stewardship teams across almost 500 hospitals. Again, this was part of the Michigan Collaborative. And that data really showed that there are a number of well-represented disciplines that comprise stewardship teams, but nurses participation is really hovering around 50% or less, regardless of the facility size. So we know that there's a lot of work to be done. And really to that end, there have been professional organizations that have been committed to looking at that. And so in 2016, the American Nursing Association, along with the Centers for Disease Control, really partnered to highlight areas where nurses can be active participants in the antibiotic decision-making process. And that was really, the goal was really to work with infection preventionists and those from academia and everybody else to really say, how do we focus on educating and empowering direct care nurses and identify opportunities really to rekindle expectations for antibiotic management, and that are also within scope of current nursing practices, because nurses manage those drugs. There was some discussion around measuring the nursing impact, and then also really to draw awareness that nurses' antibiotic responsibilities are really a tactical representation of daily stewardship. Secondly, our group really sought to elevate the position of nurses because, again, nurses really practice in all care settings. So regardless of where infectious disease physicians are practicing, or perhaps specially trained pharmacists, nurses are everywhere. So they're really that central hub for all patient care activities and interface with a number of different disciplines. And you can see that illustrated on the right. And again, that visibility becomes important because the role of nurses traditionally, the role of nurses has really been poorly understood, yet their involvement is really gaining attention at a national level. And many of you are probably familiar with the November publication of the new core elements, which really began to highlight and includes a new chapter of nursing-based actions. And I've included a few listed here. So there's certainly ones included in the different domains. So in hospital leadership, optimizing diagnostic stewardship and having discussions around antibiotic treatment. And then also in the action categories too, as far as, again, ensuring that transitions and recognizing when patients could potentially move to an oral therapy, and prompting discussions around those antibiotic reviews. And again, along that same vein, there are accrediting requirements that were effective in 2017, whereas the Joint Commission now requires hospitals, critical access, nursing care centers to also implement interdisciplinary stewardship programs and to really diversify those educational offerings to include nursing. So along that work, because when those initial core elements were published, along with the ANA and the CDC working group, I really wanted to explore the literature to see what other places and what people were doing with this work. And what we really found is that literature was quite limited. Of that time, over looking at 10 years from when the initial IDSA publication on stewardship was published, there were really only 13 nursing articles that really talked about their role. And what we found is that nurses do not have access frequently to education, both formal or informal. What they learn out of school. And then secondly is that patient safety and organizational factors influence antimicrobial management. And since that publication, it's really been exciting to see a number of articles being published on the role of nurses, as well as the increase in the number of abstracts presented at conferences. And so in fact, at ID Week, there was actually a section header for nursing and stewardship. And then just to also note that while my talk today is really focused on the United States, it's really important to note Australia, England, Scotland, South Africa are all prime examples of where, they have identified the pivotal role of nurses in stewardship and have given a number of different publications. And so, as I mentioned here, there's limited education, but there was a new article that was published by Courtney and colleagues that really identified there's a consensus-based model for undergraduate education within the UK, and really exploring what are the necessary components that we need to do to prepare nurses in infection prevention and stewardship as they continue to matriculate into their professional roles. So one study that I wanted to do is really examine how nurses at Children's Mercy perceive their role in stewardship and whether they were confident to function as antibiotic stewards. And so we found is that nurses wanted to be involved in stewardship, but what really was identified in our study is that there were a number of different barriers that they expressed to us through free text comments. And they said, practice is changing. We now have LexiComp, we have unit-based pharmacists that may be checking drugs. And so my role is really becoming a little fuzzier. And then the other thing is that sometimes my comments are not always included in rounds, or my opinion isn't actively sought out related to stewardship practices. So we've recognized that there was an opportunity to really improve the environment and where nurses were functioning. And I think that really led to kind of our focus is how do we continue to build these collaborations, and how do we make sure that we're sensitive to that workflow design, that we're not adding another step into the already busy workload, but we're really taking into account the way nurses are functioning. And I think similarly, Eileen Carter out of Columbia University found similar types of results. And she said, nurses are really enthusiastic to partner in antibiotic efforts. And so when she conducted 9 focus groups and 4 interviews with frontline nurses, nurse managers, and infection preventionists across 2 different hospitals that cared for pediatrics and adults, they said, that nurses are willing partners, but she actually recognized a number of infection prevention practices as far as mitigating the risk for infection. So for example, recognizing blood draws from central lines increased a patient's risk for infection. But she also identified that the connection between those practices and inappropriate antibiotic use was not clearly recognized by participants. So I think there's some opportunity just to help connect stewardship to recognized practices in infection prevention or commonly recognized nursing practices. And I think the other piece too is that she mentioned that those efforts to engage nurses in stewardship should really focus on the role of nurses in improving outcomes, and then also to take those implementation of nursing-driven stewardship practices and account for the context in which those practices occur, including nurses and prescribers' ability to negotiate well-accepted social and professional roles. So again, thinking about the context in which people operate, I think could be very critical when you're asking someone that oftentimes does not have appropriate education in this topic to raise a question around a topic that they may not always be comfortable with. So that really also led us to a hospital where we surveyed 9 different hospitals within Missouri to really, and these were primarily adult nurses that we were surveying. And what we found is that nurses want to be involved in stewardship. So they recognize those practices as supporting the stewardship process. So we weren't asking about role, but now that they recognize IV to PO transition as supporting the process of stewardship, so they correctly did that. They also reported that there's limited education, like what Carter found too. And then we found that there was also a disconnect sometimes between antibiotic management and medication safety. And I think, there's been some really nice research in the UK that's also discussed the same thing, where this division of labor has also been identified outside of nursing. So sometimes in pharmacist studies where they've identified that the role of pharmacists is to screen for drug interactions and to provide medication information rather than influencing those antibiotic prescribing process. We found the same with nurses as their administrators or educators. And then the second thing that I think that was really important in the study too is that nurses identified trusting systems. So again, the medical record or unit-based pharmacists, because they've been assured that the drug has already been checked. And so I think, when nurses have shared with us what would be helpful moving forward, they really suggested communication as a strategy to enhance that participation, which really brings us to the focus of our discussion today, which is how do we actually talk to nurses, frame stewardship conversation, and then also leverage existing resources that we have to help support the conversation of these stewardship efforts. And so one article that I wanted to draw your attention to is from our Australia colleagues, from Broom and colleagues, that really identified nurses as antibiotic brokers. And what they said is that, nurses are excellent system navigators and they're aware of resistance, but for them, that's not the most immediate issue. Their concerns revolve around what is happening with the patient. And so, as this nurse says, for that time, it's all about them. And so when I'm having conversations with nurses, I'm really focusing on safety. What do we need to do right now to ensure that that drug is completely necessary for the patient? So it's really around drug optimization. And then the other angle is really talking about antibiotic harm. So even though nurses are the drug administrators, what I found is that oftentimes they're not familiar with some of these different FDA communications that may talk about these increasing risks. And I've listed a number here today. In fact, I gave a presentation yesterday to some of our nursing leaders. Many of you are not familiar with Bactrim, is that, there's been some new case reports around how it's caused in pediatric populations, it's caused some severe acute respiratory failure. And they're also expanding the study, as Jen Goldman is one of my colleagues, to include that with adults. Another angle that we've been talking about too is really thinking about the number of readmissions of these patients too. So in pediatrics, the CDC is really estimating that more than 70,000 children aged 19 and younger visit the emergency room for antibiotic-related drug events each year. And so really that tenor of the conversation is on antibiotics. They're the most commonly used, but these are not benign drugs. And so the nurses must be armed with the knowledge that they can wield considerable influence within their communities as educators, as advocates for antibiotic safety. So the second piece too is really thinking about how do we frame stewardship too, because we found is that nurses oftentimes perceive stewardship itself, the term, as a prescriber to prescriber work process. And I must admit, even Jason Newland, who's well-published, well-recognized within the stewardship community, actually started our stewardship program at Children's Mercy. And when he started, even though I was an infection preventionist, I really saw it as a infectious disease pharmacist responsibility. And I think that's probably because, again, nurses are not routinely exposed to this within their nursing curriculums. And I think the other piece too is that, when we think about that term, it's not always in a language that's familiar to nurses. Nurses view safety as essential work functions. And Cindy Howe out of Jefferson Health within Philadelphia has really talked about this, is how do we consider crafting these messages in something that's familiar to nurses. And so terms that I've been using in my own practice is really around management, safety, medication safety, because that's a bit more familiar. And it really seems to resonate a little bit more in the conversations that I've had with nurses. I wanted to draw an article too, which I reread in preparing for the webinar. And I think, it's true is when I'm talking to nurses, I'm really thinking about how I'm going to sell this message. And Dr. Sexton out of Duke University really urges us to be better versed and trained in those arts of salesmanship, negotiations, active listening, communication, and even marketing. And so I've been talking with different nursing leaders, like, how do we make this a term that's a little bit more familiar? And I think, just something to kind of consider is like, how do we make that consistent and understandable? And so again, I've been preaching or talking about this more in the context of a safety initiative. I think the other piece too is again with that messaging piece is to be able to strengthen those existing relationships that are already present in many of your facilities. And that's, the infection preventionists are now expanding beyond inpatient, but also in many types of ambulatory types of settings too. They have substantial contact with nurses. They review patients who develop those healthcare associated infections, and then also can be very influential in identifying those informal leaders at the nursing and the unit level. And they participate in those teams, so they know who to really go to. And so as people who are primarily responsible for stewardship initiatives, it may be very helpful to talk to your infection preventionist to help broker that expertise, to use Broom's word, to really get those things done. And it's important for you to know too that SHEA, APIC, and the Society of Infectious Disease Pharmacists published a joint paper that really talked about how we can strengthen some of those relationships, and infection preventionists were certainly a component of that too. And in a follow-up study that's actually under review right now, they did a survey of an infection preventionist of 250 IPs that participated in a survey by the Association for Professionals in Infection Control. They found that infection preventionists are largely becoming more involved in stewardship activities. So you can see those top 3 activities I've listed here. And that, a percentage of them are beginning to assume responsibility for that nurse education too. And so while IPs in the study have really identified that further education on this topic is really becoming important, but they certainly identified that there is a natural partnership to be those educators talking with nurses around those stewardship principles and infection prevention. The other type of relationship I wanted to point out is really that nurse-pharmacist relationship. And so I think as stewards, we have that crucial responsibility in creating opportunities for involvement, but also helping leaders develop those relationships and helping nurses discover their collective wisdom. So I've been working on a study, and we asked nurses about their comfort in talking with providers and pharmacists. And by and large, nurses felt a greater ease in talking with their pharmacy colleagues because they have established relationships with them on the clinical unit. So they see them on a daily basis, and there's an openness to talking and sharing those their drug expertise. And so I have the privilege of working with Annie, and she's been working with some of our nurses because when we were around on the units, the nurses identified, hey, Annie, we noticed that we're wasting cefazolin after surgery. And, that was not really something on our stewardship radar, but nurses were seeing that bags were coming up and that perhaps were related to some of the order sets. So there was an opportunity for us to improve some of those order sets. And so again, she's been instrumental in really helping to connect that with some of the different nursing activities. And then David, who is working at Pomona Valley and now is at Stanford, has really developed that really strong, nice nursing partnership. And I'll share one of his articles that he wrote with his colleague, Mary Betty Ford. And David was really instrumental in pulling together those infection preventionists, those stewards, to really focus on infection prevention and stewardship. And so again, creating that more formal relationship there. But I think those are both really examples of how pharmacists have promoted nurse engagement, which is really, again, not about the policing of prescribing practices, which sometimes when we think about these engaging nurses, nurses may be wondering, are you asking if whether the drug is still necessary or not, that it's a more of an oversighting role, but really it's around the promotion of collaborative activities and that are really enveloped within that larger context of safety and more broadly within patient safety, which really brings me to that final group to continue those partnership is really around nurse executives. And Mary Lou Manning has written, of course, on the role of direct care nurses, but then also in 2015 published this on the role of nurse executives in antibiotic stewardship. And I think that this was also reinforced in the new CDC core elements, which really included the CNOs and regular meetings with stewardship leaders to talk about how we must assign resources to continue to promote these activities. And so you can see, as she writes, that nurse executives play that central role in spearheading strategic initiatives that keep patients safe. And then I would also direct you to Fiona Goddardsson's work out of Australia in the National Center for Antibiotic Stewardship, which really begins to think about how nursing-led programs, how they work, and what is really needed to support those endeavors as they continue to move forward. So the next part of the presentation is really talking about like how do we actually build those partnerships, develop relationships, and build opportunities to create these collaborations at the unit level. And so with that, I think, it's always important. It's easy to think, gosh, there's a number of ways that we think that we can engage nurses. But really before we start to intervene, I'd like to point out a couple key ones. Is really assessing the culture in which they work. Again, is this particularly a unit that really has very direct leadership involvement, they're fully staffed, or maybe there's a desire for them to really begin to develop skills in this area, because I think culture really can shape, and we've seen that through some of the preceding studies, that culture can shape that desire to participate, to address organizational barriers that may exist, identify nursing champions that continue to message it to their peers, as well as identify to nursing leaders what may be necessary to support their involvement, and then securing stakeholder support by both nursing, by physician leaders, and perhaps any other discipline that may be instrumental in supporting that work as it moves forward. So we know that nurses certainly understand the medication process, and you can see I've borrowed a slide from Dr. Mary Lou Manning, which really says, really from the prescribing point all the way through the drug monitoring, nurses have different components where they may be instrumental, from the identification of the penicillin allergy all the way through preparing a patient for discharge and educating them on appropriate use. And I think Olin really aligned that really nicely within her paper as well, that nurses really are involved at every segment, as well as those prevention activities to prevent ongoing antibiotic use. Yet there's still opportunities for us to clarify roles. So when I conducted the study that looked at those 9 different hospitals, I'm going to share 3 different examples with you, because we've included free text comments that allowed those nurses to elaborate really on their role and any barriers that they have. So this was a surgical telemetry nurse that shared with me, some of these questions are confusing because in a lot of situations, it's not my place to question a physician's antibiotic orders. I do not have the amount of education they do in this area. I find it unfair to expect nurses to do this. Educating patients and other tasks regarding the administration of antibiotics is within our scope. Perhaps it's the pharmacists who need to be involved more than the nurses in checking physician antibiotic orders, although I believe they already do and do a good job in my experience. And so what we found is that there were really 2 themes from this. One is that they identified their role as very binary. It's as educator, as an administrator of the drug, not necessarily across that care continuum. And then the second theme is really that desire, or that barrier of not being able to question a physician's order. And I think you see that more formally illustrated in some of Meryl's work. So she's out of Utah and has really tried to examine staff nurse knowledge as well as their attitudes with this. And what she found is that more than 80% of nurses know the indication for an antibiotic, but whether they feel comfortable questioning the dose, the choice, the route, or the duration sometimes may be out of scope for nurses, with roughly 20 to 30% of BSN prepared nurses asking appropriate questions around those therapies. 30% of nurses identified that they've given an inappropriate dose. So more broadly, I think than stewardship, these have huge patient safety implications around, and we need solutions to really address this. And Meryl's colleague, Sumner, actually had a poster at ID Week elaborating on this a little bit further, and it was entitled, "Why Won't Nurses Question the White Coat?" So again, it's not just so much about around the role or confidence in which to do it, but it's also about, again, the relationships and the environment in which they practice. The second item that we have as far as building opportunities is really to consider around fostering meaningful unit-specific activities. And so this is an ICU nurse that reported, "I feel I have a big role in nursing tasks such as properly obtaining cultures, good Foley and central line care. But in our unit, nursing does not have any input on antibiotics prescribed, effectiveness, evaluations, start and stop times, or anything else. In my unit, prescribing information is left to providers." And so nurses demonstrated a very clear expertise and understanding of strategies to mitigate antimicrobial use. For example, one nurse said, sometimes they order these antibiotics, but I don't have access to midlines in which to deliver them, which results in the time limitation to the timeliness of the administration and antibiotic delays. So Again, we saw examples of where medication management or safety was segmented by unit and sometimes very much influenced by the practice area. And this comment really came from an area where nurses are not involved when there's a positive blood culture, meaning lab calls the pharmacist contacts the provider, they discuss the antibiotic plan, and then the order is written in the chart. The nurses are not involved in what is sometimes that traditional lab to nursing to providers and so forth. And so again, thinking about what those work processes look like may very much influence what we may be asking and engagement of nurses at the unit level. And so there was a recent article by Chirani and an accompanying commentary by Simzak, which really identified that there are different decisions or conversations that can occur between surgical and medical teams, that those teams interact differently, which made me really think that there's probably not a one-size approach for integrating nurses into stewardship, and really drawing from Simzak's contributions and her introduction to some of the different behavioral theories where she's shared at conferences and through webinars. There's the Dutch method for antimicrobial stewards, which is really a participatory model. Again, it's oftentimes referred to as the IKEA effect, where it promotes more ownership if people design those interventions themselves. And so, again, I'm a nurse, I'm not a sociologist, I'm an enthusiast. And I think that those studies really give a rich dimension to the work that we do at a practice level. And so what we tried to do is thinking about what would be most meaningful to nurses. We actually engaged newly licensed nurses in advancing our stewardship efforts within nurse residency programs. And for those of you that may not be familiar, nurse residency programs are formal programs to really increase evidence-based practice into clinical practice at the bedside. It can be part of Magnet. It is part of Magnet accreditation. It's across, many hospitals have these types of programs. So again, these are nurses that have just graduated and are really learning the clinical practices within their units and really offer support there. And so we started with our nursing leadership to really gain support. We integrated it into the nurse residency program. You can see that we have 2 units represented, one our cardiology, the other is our pediatric intensive care unit. And you can see 2 very different approaches. So in cardiology, they just wanted to increase awareness, and they wanted to improve access to educational resources and to work with stewards to really augment the nursing education on the internet. Whereas the pediatric intensive care really wanted to develop nurse-to-nurse communication and integrate that during their handoffs and patient transfer forms. And I'm excited to say we've had another series of cohorts since this time, and they've continued to expand on these projects where they've included it really on what they call their nursing brain or handoff tool, because they found, we were talking about all these other body systems and we were not talking about infectious disease or antibiotics. And so there was a real opportunity for nurses to talk with one another, which would hopefully advance conversations within the prescribing teams too. But again, we floated ideas out to them, but these are projects really completely owned by, developed by, measured by our frontline nursing staff. And so I think it's again about meeting nurses where they are and allowing them to champion those efforts and what's important at the units in which they are practicing. So I mentioned David Ha in a few earlier slides. And so again, he worked with Mary Betty Ford. And what they did is on a step-down telemetry unit, they conducted twice weekly rounds. And what was really interesting about it too is that they engaged educators, infection preventionists, frontline nursing staff, and they really structured it around nursing workflow. They talked about devices, they talked about antimicrobial use, and you can see that they saw significant reductions in antimicrobial use in specifically community-acquired infections, and they also found a decline in the usage of urinary catheters too, so the duration of those. But I think it's a really nice example of marrying infection prevention and stewardship, because again, it kind of meets with things where nurses are oftentimes very familiar with infection prevention and are responsible for leading a number of different initiatives like our central line associated bloodstream infections or CAUTI teams. So the third item that I wanted to suggest too is really around building confidence. So along with clarifying role and selecting meaningful unit-based activities, I think there's an opportunity to really think, how do we consider nursing confidence in this topic? And so as this nurse reported, education is needed. If we feel confident to suggest antibiotic changes to doctors, we will do so. The only thing I can think that would not make us want to participate is because we feel we could suggest the wrong thing. Also, doctor to nurse communication needs improvement. So again, this was not an isolated comment where nurses were concerned about being wrong. And in a setting where we know education is oftentimes limited for nurses, it really does shape their involvement and that desire to know what's right. In fact, I was talking with our new nurse residents in the pediatric intensive care, and I said, where do you go to find antibiotic information? Is this brought up in rounds and so forth? And like, no, because there's the pharmacist, and they're already talking about some of these different drugs, and they use this model of flipped questioning. So we are an academic medical center, so oftentimes the intensivist would flip the question to the resident. So why do you think they're on antibiotics? And a method that works maybe very well for one discipline was really quite intimidating for the new nurses. And so again, just thinking through, like, are there different communication strategies that we may need to have depending on the groups that are engaging in these types of efforts? So we know that from the patient safety literature, there are practice guidelines or conversational tools and algorithms, and structured communication can sometimes be helpful in dampening the hierarchy or different communication issues that teams may be having. And we can see that bearing out in the infection prevention literature as well, that there are algorithms for deciding appropriate indications for urine cultures, group-based strep testing to ensure that we're not testing those that are colonized, but truly that do have infection, and then nursing-driven practices to decrease central line associated bloodstream infections and UTIs. And so again, that's really gleaned that that nurses have been instrumental in reducing those device-associated rates by leading practices aimed at removing or appropriately managing those devices too. And so in our practical approach, it was important to us to identify some different ways that this communication may unfold. And so we have different scripts for allergy history. So again, how might a nurse clarify an allergy history when someone says that they've reported perhaps a side effect? Or SBAR, which stands for Situation, Background, Assessment, and Recommendation, which has been used in a number of different high reliability industries such as aviation and so forth. And you can see embedded within our patient safety literature too, which really talks about tightening communication. And so again, this would be an example of a physician who's ordered C. diff testing, but the patient's on laxatives. And so the nurse needs to raise the issue of, should we stop the laxatives and reassess for C. diff testing at a later time? And it reduces this concept of hint and hope, because I think, again, in my practice, nurses and providers are socialized differently in how they communicate. And sometimes nurses introduce a softer way of communicating with the idea of just hoping that the provider will understand and it's not perceived as challenging. And SBAR and other different tools can sometimes help reduce that ambiguity in conversation. And to that end, the Agency for Healthcare Research and Quality has now published their safety program for improving antibiotic use. And within that toolkit is the team antibiotic review form, which is really framed around Pranita Tama's 4 moments of antibiotic decision making. So does this patient have an infection that requires antibiotics? Have I ordered appropriate cultures before starting antibiotics? 1 day or more has passed. Can I stop or narrow antibiotics? And what duration of antibiotic therapy is needed for this patient's diagnosis? And what I particularly like about the tool is it actually frames those 4 moments, but then it allows the whole team to really consider and help really understand what the current plan of care moving forward is. Because I think when nurses are engaged in that effort, they then can better communicate it to the families, to the patients, around what those expectations look like. And so in a similar type of model, this past year, we've been studying the feasibility of a nurse-to-nurse handoff tool. And so what this antibiotic engagement tool is really framed around whether the antimicrobial is present, what's the duration, and you can see that over on the right, the indication, whether the patient is taking things by mouth, so oral, and suggestions. And so what we really found is that when we approach nurses on talking about antibiotics during transitions, be that shift to shift, or as a patient is being discharged or perhaps transferred to the ICU, they really asked us, like, what would you like us to talk about? And so together we developed this really antibiotic assessment where nurses can use that to identify areas where they may need to speak with the team. And what we've begun to find in our data analysis is oftentimes nurses know the indication, it's the duration, particularly in light of multiple therapies. How long is the intended plan for the duration of this drug? And so, again, too, is that duration may not always be updated, after labs. So again, if the patient comes in as rule out sepsis, and then as the diagnosis becomes narrowed, again, sometimes that information is not always made clear. And so on the flip side, we actually thought we would introduce a number of different modules, and they're like, Elizabeth, we need you to slow down. It would be very helpful to have education on the flip side of the tool. And so you can see that we've listed, like, why do we care about the duration or the indications? And then what's really relevant around transitioning to an oral therapy? Because again, this may be the first time that this is introduced to many of the nursing staff too. And you can see too, for many of you who may be familiar with more of the lean methodology, this uses the format of the Kamishibai cards, which have been introduced within the infection prevention literature and have shown successful reduction of CLABSI, of UTI rates, that promote that conversation based on best practices. So I've shared a number of barriers, but I also wanted to provide a reference to you of a recent study that really quantified those issues, like competing demands, so time constraints, or physician pushback or scope concerns. And so you can see in scope, and approximately 70% of nurse respondents had identified that is a concern and a barrier for their full participation in stewardship programs. And so when we were actually trying to implement our tool within 4 different practice sites, we had providers questioning the concerns around the independent practices of nurses, or reviewing susceptibilities, as they didn't perceive that nurses should be looking at that type of data. And so what we did is we developed an SBAR. Again, I was working very closely with Jennifer Goldman, who's my medical director. So we developed a tool. It was disseminated to our hospitalists and those in graduate medical education, because we found that providers weren't familiar with what we would be asking of nurses, and that they may be asking them questions around the antibiotics, and it's really designed to be a shared learning opportunity. And so we detailed those study objectives. We emphasized the provider partnership in this. And then we also found is that it was really important, particularly for our colleagues outside of Children's Mercy, is to really soften that language with consider or help optimize. And then again, along that vein of pharmacist to nurse relationships, many of them really wanted pharmacists to be that primary point of contact to minimize perhaps further interruptions and discussions around the plan, because the pharmacist was at the unit level and would be able to receive those questions. And so again, just remembering that we've got these different stakeholders that probably need to have awareness of what might be happening at the unit level. And then as I prepare to close, one final study that I wanted to share with you, and I think what is really interesting and important about this is it recognized how relevant bidirectional communication is in ensuring that nurses can appropriately prompt those antimicrobial reviews. And so this occurred in a critical care unit. They used a standardized script for interdisciplinary rounds. It was part of a quality improvement project. And what they did is that they had a few different iterations of the project, but what they realized it was most helpful when they primed providers with the ability to respond with affirmation, rationale, and those clinical decisions. So again, if I'm Nurse Elizabeth and I'm raising the question around the duration of antimicrobial therapy, it would be then appropriate, like, yes, Elizabeth, it is our intention to continue this therapy for the next 3 days, and here's why. And they found that was really the part that resulted in the reduction of days of therapy. And I think that concept of really introducing of how teams make sense, or sense making, that shared understanding, and creating very open conversations and feeling safe to question the decisions of those sometimes with more authority. So as I close, as you can see, it really does take a village to advance those stewardship efforts, to develop it as a collective mindset, and really a shared purpose amongst all those different clinical teams. I think it's important to utilize existing work processes, to partner with infection preventionists and nursing leaders and pharmacists to solicit feedback directly from nurses and to identify relevant areas to intervene. Again, may have a very good idea of what might help, but be able to kind of narrow those discussions and allow people to really identify, like Annie did with the cefazolin on one of our particular units. And then finally, that learning is really a social act. It flourishes through interaction, through communication. And so interdisciplinary teams can really boost that collaboration, but it also allows teams to draw on that collective wisdom of their clinical partners. And so I've just finishing a book called The Geography of Genius. And the gist is really, genius is not wholly innate, but rather it creates space for creative solutions, which really occur within communities that are open to new ideas and to experiences. And to me, that's really our job as stewards, is really the essence of partnering with nurses. We are entering a space where we can reimagine what stewardship looks like. And I think that's very exciting. And so again, creating that environment where all those different disciplines can come together and share what's relevant, I think is a very exciting, and I'm looking forward to being part of those future efforts. I'd like to acknowledge the happy group of stewards that are listed here from Children's Mercy, in particular, Dr. Goldman, Wirtz, and Lee, who've been instrumental in a lot of the nursing-driven activities within our facility and in some of our other multi-site studies. And with that, I'd love to take any questions. Thank you.
Thank you so much, Dr. Monsees. That was terrific. And I just really like how you took us through the contemporary literature to give us a thorough understanding of where we started and where the area of nurses' role and understanding their current role in stewardship. I want to also let our participants know, please stay on the line. The question and answer session is beginning now. So this is your time to engage with Elizabeth. So go ahead and send those questions in so we can address them here in the next 15 minutes. One question that's come in is Elizabeth, I don't know if you can see that or not, but is there any work being done around nursing involvement in outpatient stewardship efforts?
Yeah, so I think, one of the areas that, particularly in our own hospital, what we've been doing is the Group A strep algorithm. So again, appropriate testing. In fact, when I was talking with a group of nurses yesterday, they happened to practice in an area that had that algorithm. So it was in one of our urgent cares. So again, testing in children less than 3 years of life is not recommended unless, of course, the parent demands it. Then there's actually a different laboratory code. So it does help kind of identify that a little bit differently. So that's one example. And then actually when I've talked with outpatient nurses, one area that they're particularly interested in is penicillin allergy testing. I think that is really drawn from the fact that oftentimes, they're recognizing those side effects, but how does that communication actually look to the parent and then is then disseminated to the provider? And so again, aside from those algorithms, I think, outpatient, I haven't seen as much work other than perhaps in a diagnostic fashion where they're trying to do specific testing. But I think, within my own facility, we're trying to look a little bit more around penicillin allergy testing and engaging those nurses in conversations around that and talking with our parents around appropriate antibiotic use.
Yeah, it seems that ties very nicely with the primary concern being, first patient safety. Mm-hmm. In that perspective. I wanted to just go back to one of your original slides, the study by Vaughan, mm-hmm. that looked at the percentage of hospitals, and it didn't seem to matter by what bed size it was.
Correct.
Only about 50% of the teams had a nurse involved on the team, on the antimicrobial stewardship team. What year was that? Do you recall what year that study spanned? And I'm curious if that's changed at all.
Yeah, so I believe that she completed or sent this to the infection preventionist it was May to October of 2017. So again, another year later, potentially more nurses may be involved, but I can tell you that I think that people still struggle with it. We're involved in a couple different collaboratives, and facilities have reported, again, how do we actually engage nurses has been a bit challenging because again, it's setting aside monies in which nurses mm-hmm. can attend meetings or be involved in unit-based activities too. And so I think that also gets to the measurement piece, which is why that becomes so very important, is what are we really asking of nurses when we want them to take an hour or two to be engaged in this work on a routine basis? What are we expecting that activity to look like at the unit level? And so I think there needs to be more research, more quality improvement efforts that really begin to identify when nurses are involved in those discussions. And I think David Haas shows that really nicely. When they're involved in those discussions, we're actually reducing the number of devices, we're reducing therapies, because now nurses are prepared to have conversations with those prescribing teams.
Right.
And so
the
please go ahead.
tools.
Yeah, exactly.
Right.
Exactly.
And I want to talk a little bit more about that. We've had some other questions come in and I want to get to those. One of them is around improving inappropriate ordering of urinary analysis testing for foul-smelling urine without symptoms. Have you seen any in your institute as you've implemented some of these programs that other frequency of ordering tests that maybe in the past would have been more frequent, but that's shifted due to this education?
In our facility, because again, we're pediatrics, we haven't had as much focused effort on that. I will tell you, in long-term care, I know that several of my colleagues that we've talked about within the stewardship component, that's been a key driver or a key important issue. That again, how are we educating nurses that if urine does smell bad, it's concentrated and so forth, that you're not routinely ordering those urine cultures. And so I think that's been very successful in that type of setting. In acute care, I think that there's still some ongoing work. I think another place, not necessarily around the specimen collection, but I actually had a nurse approach me at one of the conferences, and she said, it's in many ways, antibiotics are kind of like Foley care, in that, during discharge rounds, nurses are raising that question to the prescribing team and saying, this patient looks like it could probably go home, but it still has a device present. And then it's prompting discussions with the prescribing team that they may be able to switch them over to an oral therapy, remove any devices that may not be necessary now, and actually promoting a little earlier discharge than sometimes what's been done in the past. So to answer that question, I think in my own experience, I haven't seen it quite as frequently, but as more of our focus is sometimes on respiratory specimens, but you certainly are seeing it in other areas. That's a great one.
Okay, yeah. So just going a little bit back to the Vaughan study. So it's, remarkable that all teams had a pharmacist present on the antimicrobial stewardship team, but the nurses were about 50% at that time. So it seems to me, if we have several participants listening today that are pharmacists, most likely on antimicrobial stewardship teams. If they don't have a nurse present on the team at this time, what's your recommendation of how do you take that next step? And who do you talk to? Where do you go to a nurse leader? Or I'm just curious how you proceed.
So what we did is at Children's, we're very fortunate. We have a chief nursing officer that's very supportive of nursing activities around this. And so, when the ANA CDC document was coming around, so we were already having conversations that, and that there are accreditation requirements saying that we need to be engaging nurses in discussions around antimicrobial resistance, and again, further illustrated within the CDC core elements too. And so we had conversations with our nursing leadership about that, because we found is that even though we could talk with direct care nurses, and they saw that connection, we still needed to have leadership support, one, for their time, and two, so that nursing leaders more at the unit level, so those departmental directors or managers could also help support that and encourage and remove barriers that nurses may be experiencing. So what I would say is to the pharmacists that are really responsible for these stewardship efforts is really to begin to identify, perhaps from your data, are there places where involving nurses in discussions would be beneficial? So again, examining a few ideas, and then potentially approaching, be that unit leaders and potentially your CNOs, around, again, these are the new requirements. And I think the angle that might be helpful is in the core elements. It does specifically include CNOs as individuals that should have regular meetings with stewardship leaders. And so within that document, I think in fact, it's something we need to probably look at a little further at Children's Mercy, is how routinely do we talk to our administrators around all levels of engagement. So like I
Right.
said, I would talk with the directors at the unit level. I would identify frontline nurses that may have an interest, that are already naturally engaged in that, and then consider like how to embed that in conversations with your administrative leaders as part of the core elements.
Yeah, it's exactly right. With the new core elements, and you have that component, now you've got that piece that you need as a pharmacist would engage with the administration about why this is critical and important
Mhm.
through that mandate.
And the
Um,
other and the
yeah.
other piece, I'm sorry, and the other piece too is I would talk with the infection preventionist team too, since they're
Mhm.
oftentimes, probably reporting out some of the data that you're reviewing and using for your stewardship work. Is maybe there's an infection preventionist that may have an interest, and that is being discussed at our annual conferences on a routine basis around the IP's role. So again, just another person that can potentially help you navigate kind of that nursing system, or potentially those administrative leaders, because IPs routinely have to do those reports to the board and other administrators.
Yeah, that was one of my questions I was going to ask you is around the close link between infection prevention and some of the nursing safety and initiatives, and the impact that some of the outcomes that the studies are showing are in preventing infection
Mm-hmm.
as well. So there's a really close tie there. Um, so another interesting study you presented, I have it on slide 26, was around just where the nurses understood the indication, quite high percentage of them. But then when you got into optimal dose and duration, it all those different categories were, maybe a 25% comfort level there
Mm-hmm.
in understanding that. And so as you were speaking, I was thinking that around, where's the opportunity? Where do you first target? And it seems that in your tool, which I wanted to ask if that's available, like could the participants, would they be able to have access to the
Yes.
tool you presented later in the slide deck?
Mm-hmm. Yes. And in fact, we're moving, that was part of a grant through APIC that was sponsored by BD as their Heroes of Implementation Science. And so we'll actually be publishing on that early part of next year. And so we're still in the data analysis, and we have some ideas of how we might want to revise it, but certainly that can be available to people who are participating on the webinar. And if they have any
Yeah.
questions, they can contact me directly. As like I said, we're continuing to understand how helpful this is to nurses. But to answer your question, I think the duration might be an area potentially to continue to help nurses. One thing that I would say that would have been helpful in the tool too is if there were multiple antimicrobials listed. So for example, on the AHRQ tool, there are, and you can see that, I think there were up to 4 or so antimicrobials that the patient may be on. Our tool didn't list that. And so in hindsight, we probably should have created space for that because when we found that there were multiple ones ordered, that's when they reported it was sometimes a bit unclear as far as the duration or the plan moving forward. And so that might be an area
Yeah.
to help clarify for nurses too. And I think the other piece too, when we've talked with them about the indication, for the most part, that they understand that piece, but then if there's any potential changes too, that as your diagnosis is becoming more narrow, as you have more labs, is to review things and to prompt questions with them. Are there any questions or things that you're seeing that may be relevant to our decision making? Because again, making that connection between the two teams becomes really, really important.
Absolutely. And the duration, and then another one that you brought up as well was the IV to oral
Yes.
switch that can occur. And then with the educational piece, it sounds like you're doing educational, you've got an educational component that is probably most likely ongoing. So you're able to keep them up to date on some of the contemporary literature you described today.
Mm-hmm.
Would help to give them greater confidence.
Mm-hmm. And it's interesting because even like the IV to PO, nurses have reported, that they've identified different opportunities, but again, connecting it to the actual practice that question could help the physician then either identify an oral therapy. And so again, we've done that through a variety of our different nursing groups when we've educated. So not only on the back of the tool, because again, this was only being tested in 2 units, but we have other units that have a modification of the tool that they've used for their nurse residency program. But, again, just bringing up the fact that providers or even pharmacists may not always be aware of what you're seeing at the bedside, which is, this
Really
kid's,
important and
yeah.
integral. So what my final question, and feel free, any participants that I see there's many people still listening. So if you have a burning question, please send it to us now. But I thought it was interesting, and we know this happens in clinical practice around the laboratory data being reported regarding susceptibilities or the, diagnosis, reporting out a microbe that's present and how that would change therapy, but that information goes to the antimicrobial stewardship pharmacist or the provider, and then the nurse isn't included in any of that component. So I'm curious, have you shifted the workflow so that they're now included in, or how do you do that?
And I apologize, I should clarify. So in our facility, yes, nurses are contacted. So when laboratory identifies that result, it would be contacted to nursing, and then there'd be discussion. This was in another facility, so it was an adult facility. And so
Okay.
one of the things is that the nurses had shared, that we're not included in those discussions. Well, long story short, it's probably because they aren't always involved in, at that facility, the lab would call the pharmacist, not necessarily the ASP pharmacist, the unit-based pharmacist.
Okay.
Then that's where the discussion. But then when we introduce that engagement tool in 2 other adult sites, that's also where sometimes different facilities, even the medical team said, they don't want the nurses necessarily to contact the prescribers. They want them to contact the pharmacist. So I think there's more and more conversation that's really occurring between nurse and pharmacist around antibiotic plans and always nursing to prescribers.
Mm-hmm. Okay.
Yeah.
Thanks for
But
clarifying that.
yeah.
Yeah, I think that's an important component as well. And obviously, as you get nurses engaged in the stewardship team, I would think that naturally those things would start to transition into the flow of information as shifts to include all members of the team. All right, one last question from our participants here that we need to ask. Your recommendation, Elizabeth, to ensure the microbiology culture sample collection by nurses are done appropriately and in a timely manner.
Mm-hmm. So there is, and you can see that listed in the core elements too, around the concept of diagnostic stewardship that, again, and that may also be part of where IPs can be involved, is making sure that specimens are collected appropriately. And so that's really what I think you're referring to, the Olin slide where it says assuring microbiology results, and then it's kind of woven throughout too, is that we are appropriately collecting the specimens so that the lab can then reconcile those and interpret those appropriately. So the one thing I found sometimes in conversations with nurses is that, and again, trying to understand the context of the question, nurses will review the lab results, but it's the interpretation of the susceptibilities that they sometimes have trouble with because it's not always delivered within their nursing curriculums and then later reinforced in practice. So they actually saw that almost as 2 different practices. In other words, I would collect the specimens, I will review the specimens, but as far as the actual interpretation, so somehow that susceptibility looks different to them than perhaps other laboratory data, like looking at electrolytes before looking at that labs before administering electrolytes, or so it's interesting that there's a component of microbiology that is seen as a little bit of a different practice.
Yeah, it's missing. And so that's the educational opportunity as well. Correct. Well, we're out of time, unfortunately. I just wanted to thank you so much, Elizabeth, for joining us today. It was just a terrific, very timely and contemporary presentation. I want to thank our participants as well, and remind you that the webinar is recorded. So if you'd like to listen again or share with your colleagues, please visit our website at CIDRAP.umn.edu/ASP, where we archive all of our recorded webinars there. And thanking Dr. Monsees again for your insights and all of your leadership at the societies that you contribute to is very important. and your research, and thank Maya Peters from the CIDRAP-ASP team who has helped me in planning and producing this webinar today, and to thank our listeners for joining us today. And visit our website and sign up for our newsletters to stay up to date. With that, I'll close. Thank you, Dr. Monsees.
Thank you.